Welcome back to OMFS Essentials. Poor planning is the major cause of difficulties and complications during third molar surgery. A successful, uneventful procedure hinges on meticulous preoperative evaluation. This process is divided into three parts: clinical history, radiological assessment, and pre-surgical preparation. 1. Clinical and local evaluation. A complete medical history and physical exam are mandatory. Locally, the following points must be assessed. A. Age and bone quality. Younger patients, removal is easier because the bone is more resilient and elastic. Healing is faster. Older patients, over 40, bone tends to become more compact and sclerotic, losing its resilience. Simple impactions may become technically much more difficult due to the rigidity of the bone. B. Oral condition and access. Acute infection or trismus must be managed before definitive surgery. Soft tissue. Note the condition of the surrounding tissue. Inflamed, congested tissue bleeds profusely during surgery and has retarded healing. Access factors. Note any factors that interfere with access, such as a hypertrophied buccal fat pad, macroglossia, large tongue, excessive salivation, or an exaggerated gag reflex. Oral submucosal fibrosis. In patients with OSMF, the removal is exceptionally difficult due to restricted mouth opening and stiff oral mucosa. Forceful retraction risks tearing the stiff mucosa, leading to significant bleeding. C. Tooth integrity and relationship. Crown condition, a carious or non-vital crown, is fragile. Note its size. A bulky crown often requires planned odontectomy or splitting to prevent damage to the adjacent tooth and to minimize bone removal. Adjacent second molar. Critically examine the second molar for caries, cracked tooth syndrome, or periapical infection. Assuming pain is from the impacted third molar when the cause is the second molar will result in persistent post-surgical pain. If the second molar is endodontically treated, it is brittle and can easily fracture if elevators are used improperly. Impaction relationship. Mesioangular or horizontally impacted crowns may lie below the height of contour of the second molar. This requires splitting the third molar to safely remove it without damaging the second molar. 2. Radiological evaluation. Radiographic assessment is crucial. While a high-quality periapical film may suffice, a panoramic view or lateral oblique view is required to fully visualize deep or posteriorly placed molars. A. Key radiographic features. Roots. Study the number and morphology. Are they fused, conical, divergent, delacerated, or hypercementosis? Complex morphology increases surgical difficulty. Pathology. Note any associated carious, undermining, periapical pathology, cyst or tumor formation. Angulation and depth. Classify the tooth using the Pell and Gregory and Winter systems. B. Inferior alveolar canal relationship. The IAC is typically buccal to the roots, but due to 2D superimposition, it can appear intimately close. Critical signs indicating real proximity or involvement, J.P. Rude criteria, include changes in root, darkening, radiolucent band, deflected or narrowing of the root apex, changes in canal, interruption, loss of the superior white line or cortical plate, or narrowing, converging, canal path. C. Tube shift technique, or Clark's rule. This rule determines the 3D position of an object, like the root apex, relative to a reference object, like the IAC, when the X-ray tube's horizontal angulation is changed. Rationale? If the tube is shifted mesially and the object in question moves in the same direction, it is lingual. If it moves in the opposite direction, it is buccal. Benefit? This helps confirm if the root is truly lingual to the canal, or if the proximity is merely an artifact of superimposition. D.
CBCT. If the 2D film shows any of the critical proximity signs listed above, the use of CBCT is highly recommended, as it provides accurate 3D information on the root apices and the position of the IAC. 3. Pre-surgical preparation and prophylaxis. A. Investigations. The minimum required investigations before any elective surgery include a complete hemogram, urinalysis, and coagulation profile, bleeding time, and clotting time. B. Part preparation. Preoperative, the patient should use an antiseptic mouthwash, chlorhexidine or povidone iodine, for at least 24 hours before surgery to reduce the microbial count. Immediate pre-surgical, final extraoral and intraoral prep is done using 5% povidone iodine solution. The perioral skin is prepped since the surgeon and assistant will touch it during retraction and mandible support. C. Pre-medication. Antibiotics, prophylactic antibiotics, typically a beta-lactam group drug, should be prescribed preoperatively, especially since the contaminating flora is gram-positive, oral flora. Sedation. For anxious patients, diazepam, 5 to 10 milligrams orally or IM, is given to relieve anxiety. Secretion control. Atropine sulfate, 0.6 milligrams IM, is helpful for its vagolytic action to reduce salivary secretions and prevent a vasovagal attack, bradycardia. D. Anesthesia. Most cases can be performed under local anesthesia, lidocaine with adrenaline. For prolonged procedures, a long-acting agent like bupivacaine, 0.5%, can be used. General anesthesia is reserved for uncooperative, mentally retarded patients or for very deep impactions requiring extensive, long surgery. 4. Prophylactic versus therapeutic removal. The surgical philosophy often falls into two camps. Early prophylactic removal, removing the tooth before root formation is complete, late childhood, adolescence. Advantages: surgery is easier, bone is elastic, the pericoronal space is wide, and operative morbidity is reduced. Late therapeutic removal, removing the tooth only when it becomes symptomatic. Disadvantages: unfavorable root morphology, brittle or sclerotic bone, more difficult surgery, and slower healing. While prophylactic removal offers significant surgical and healing advantages, patient motivation is often a challenge when the tooth is asymptomatic. Comprehensive patient evaluation, integrating history, precise radiological assessment, and appropriate pre-medication is the foundation that minimizes surgical complications and ensures a smooth, predictable outcome. You've been listening to OMFS Essentials. As always, keep mastering the essentials.